So hi, Jordan. Welcome to the Good Mood Podcast. Thanks for joining me from your cottage.
Thank you for having me. Yeah, this is a perfect place for us to talk about mood. Look at my beautiful backdrop I have back here of
Yeah,
trees.
I know. It's nice. Where are you? Where is your cottage?
We're kind of in the Bancroft, Halliburton area. Mhm.
Okay. Yeah, I have a friend that I think that moved there to start beekeeping, like a CCNM
To start
grad.
beekeeping.
Yeah, yeah,
Yep.
yeah.
It's such a beautiful area up here. I adore it.
Yeah, it's beautiful. Yeah, with a lake, and yeah, you're just nature immersion and ecotherapy time. Yeah, amazing. So I invited you on so we can talk. You were a hormone expert, so your focus is essentially women's health. Yeah, and also you are very adept at research, and I think your background was in research, wasn't it? Yeah.
It is, yeah, and not like test tube pipetting stuff research, right?
Mhm.
Like that, not lab coat kind of research, but more like literary research, which is using other people's primary research to pull together and draw conclusions to, kind of try and understand more concept-based type research versus, I would say like pipetting things,
Yep.
but like that kind of research.
Right.
So yeah, that's my background. My background is in critical appraisal, it's called, which is where you read research and then decide if it's true or decide how it's going to shift clinical practice, which is kind of where it's kind of more important for us as practitioners. Like if a
Mm.
study comes out, do we do anything with it, right? Do we change what we do with patients because it was published? That's kind of where my area of expertise is.
Right. It's very useful as NDs. Like I think we think of like medicine. I've heard it referred to as applied science. So you're taking all the pipetting research and the test tube stuff, and then the actual review articles and things that get published, and then you're figuring out how to apply it to real life
Mm-hmm.
examples on the ground. Um, yeah, which is really helpful in the naturopathic field because I mean, we do definitely have a research arm of naturopathic medicine, but then we also have our traditional roots too. So, I mean.
Yeah, I'll say where I think we benefit from it the most is just being able to adapt to the changes in medicine quickly, right? So from a public health perspective, when things kind of get, sort of that top-down approach, the amount of research and the amount of policy change and all of that happens for the government to say, yeah, eat more fruits and vegetables, right?
Right.
We can turn on a dime to say oh my God, the study was published that says we should eat more fruits and vegetables. Let's talk about that today.
Right.
So I feel very fortunate that we get to work in that realm, and that I find that research, sort of side of myself actually really just benefits my patients because they don't have to wait the 7 to 10 years for some study to turn into public health policy. Is that we can at an individual level have those conversations in the moment, which I think is so powerful. And I think that's where this sort of whole, because we want to talk about hormones, that's where this sort of whole hormone conversation comes up, right? Is that our, the trends and how we treat things hormonally kind of shifted in the 90s, and we have had a very slow shift back to focusing on hormones as being a part of a woman's mental health. Even though the research kind of in the late 90s was oh shoot, we were kind of wrong about that. We should shift gears back to talking about hormones. That still hasn't disseminated into clinical practice, even in Canada. So yeah, so I feel lucky that we get to just move with the information, right, as it comes out.
Yeah, and acknowledge hormones as a cause of mental health symptoms and emotional symptoms, which is not necessarily completely pervasive. Like a lot of patients are surprised when you validate their experience of, yeah, hormones have an effect on the brain and actually affect your mood. They're like, oh, thanks. That's very useful for me to know because nobody's really validating that. And I know you've written about that too, where sometimes people feel like their experience on the pill or with hormonal replacement therapy, or even their experience throughout their cycle is almost dismissed sometimes, where it's like, oh no, that's not the cause of, you're depressed, you have a brain chemical imbalance. It's nothing to do with estrogen or your hormones. Yeah.
Because mood, and I know you know so much about this, Talia, mood is tough because there's not a lot of objective data that we can get, right? Which in medicine, and I don't mean me and you, I mean just medicine in general, we
Right.
like to reduce the experience of the patient down to numbers, lab work, measured things, right? Where with mood, we have a hard time doing that. And with hormones, we also have a hard time doing with that. And so what that leaves us with is this more subjective experience, I say in air quotes, of the patient, and this sensitivity to their hormones, which we'll loop back to because I do want to explain that. And both of those like feel abstract in medicine, right? Like we can't really hang our hat on the way the patient talks about their mood, and we can't really hang our hat on what's happening with their hormones because it's actually their sensitivity to their hormones. It's not that their hormones are awry, it's that they just feel unwell based on their hormones. We hate that in medicine, right? We're like, well, we can't really measure either of those two things. And so they're probably not as important as, the patient feels or as that truly is, which is why we end up being so dismissive about it, right? So for example, if a woman, goes into her family doctor's office and says, I know my mood is related to my hormones. Can we test my hormones? Right? And maybe reluctantly, their family doctor will say, well, sure, we'll test your hormones. They come back normal 100% of the time. Right. And it's not because she's not having mood symptoms because she has hormones. She's having mood symptoms because of the way she feels. She is sensitive to her hormones and the changes in her hormones. So for example, for PMS, it's the change in her hormones that makes her feel unwell, not that they go from 100 to 200, or it's not the crude number that matters. It's the change. So when we try and measure that, we go, like it looks fine, right? And then it dismisses her experience, right? Because she's like, well, my doctor tested my hormones and apparently they're normal. And so then she starts to internalize this, experience that she's having as some kind of fault, right? Or it's now we have to seek some other kind of meaning behind it because we've discounted the impact that her hormones are having on her mood.
Right. So maybe it's actually my relationship is terrible, even though it's only terrible 1 week out of the month,
That's right. Yeah. Yeah. Or it's a brain chemistry imbalance, or which is where we start to like seek treatment strategies that maybe are not all encompassing, right? Because, and yes, like when we can talk about the antidepressants, like time and place for sure. And for some women, absolutely life-saving, especially when we're talking about PMDD or the more extreme sort of psychiatric version of PMS, absolutely life-saving, right? For those women. But that's not the only answer, especially for women that are suffering with mild to moderate changes to her mood through her PMS window or during peri-menopause, or I'd say like over the age of 42. We really need to start thinking about that underlying deep impact that hormones are having on her mood. And an antidepressant doesn't necessarily solve the problem. Or maybe it partially solves the problem and gives them lots of other problems like low libido and whatnot.
Right. Yeah. Well, because if the root cause is something that we say a lot, but if the underlying mechanism is actually these hormonal changes, not necessarily your serotonin levels in your brain because you were born with something kind of off in terms of brain chemistry, which is the story, then maybe the antidepressant helps because it's helping with some like a manifestation of that hormonal imbalance or hormonal changes that are going on. But it's but those hormonal changes have other symptoms, not just mood. So, low libido. So there's other things that the antidepressant may then cause. Yeah. So we're not necessarily being direct with treatment, which could be a problem in and of itself. So, yeah. And it's interesting when you're talking about, patients will say that a lot. They're like, I've asked for, sometimes we'll get hormones tested in the luteal phase, but again, it's like a snapshot. It's like a screenshot of this entire video that's happening throughout the month that is not going to give you that much information. And many conventional doctors will say, well, we're not going to test because your hormones change. So, and then like you said, they always come back normal because the reference ranges are pretty large. And it's not the absolute number that's the issue. It's how things change and work together.
It's how they change. Yeah. And so, some of the most effective things that women can do is track their symptoms through the month, right? Because that helps us understand what her experience is through the month and can maybe give you a better understanding of those pockets of time where things are well and things are unwell. The other thing we often do in peri-menopause is we use a period as this end all be all meaning like, well, you're getting your period regularly, so your hormones are fine, right? Whereas really, hormone changes start, and I always use the like the age 42. Like anything over 42 can be a bit of a wild card when it comes to hormones. But anytime women have shifts in like how likely they are to ovulate, meaning that they maybe are not ovulating every month, or shifts in like their maximum production of hormones, which also starts to happen through perimenopause, she might bleed every 3, 4, 5, 6 weeks, right? And often it starts to become a bit more regular during that time in a woman's life. The bleeding doesn't mean she had good hormone production, right? But we often make that correlation, right? When we use it as a surrogate outcome and say like, well, you have a period, so your hormones are there. You're not menopausal because you had a period.
Right.
But meanwhile, the underground, pieces that are happening there hormonally are not normal, or they're just shifting, right? Perhaps it's normal for us to have some changes in hormones as we age, but the hormones are shifting even though she has a period. So it's the same as the lab work, right? Like we do the lab work, it looks fine. We say you're fine. We track their cycle. They're still bleeding. We say, oh, you must be fine. Right. When what's actually going on under the surface is way more haphazard, right, than it's supposed to be. And so women will get these pockets of time where they don't feel well. And as a practitioner, the woman's like, always like, are you psychic? Like, how did you know that like these days are going to be amazing and then these days are terrible, right? But it's because if you truly understand what's happening during that menstrual cycle and you get women to track, I can tell you when you don't sleep well. I can tell you when your skin's going to break out, or when you're going to feel like running for prime minister because you're super confident and feel like you can do everything.
Right. You're like, I'm prime minister this week. And the next week you're like,
that's right. And then you can't even like 24-hour plan, right? A few days later, right? Let alone 5-year plan.
You're like, how can I be prime minister if I don't know what pants to wear?
Exactly. So I think getting women to track that, right? Because then they start to like feel a bit more empowered about how their hormones are actually impacting their health. And it makes it for a much more productive conversation with their practitioner to be like, look, I got like insomnia, night sweats, vaginal dryness. I can't stop urinating during these 3 days, right? So yes, I get my period a day or two later, but those are symptoms of perimenopause, right? That's showing us that your estrogen amplitude is not enough to keep you well all month long. And that's where the mood symptoms are going to start to creep in, right? Because that's deeply connected to your serotonin levels.
Right. Yeah, exactly. Because we think of things like we want to think of things as this thing does that. But when it comes to hormones, there's a whole network of effects. So,
yes.
And actually, I was curious. So when you have people track, and then over time, you've seen many patients tracking their cycles, and then of course by reading the research and understanding how these hormones shift experience, and then you bring things up like, oh, I bet you this is when you don't sleep, and people are like, like you're a wizard. Can you maybe explain what those effects are? Can you maybe take us through a typical cycle that's kind of imbalanced and do the wizardry?
So for sure. So and we'll try and relate it to mood as much as possible, but throw in the other symptoms too. So during that like early phase of your menstrual cycle, so day 1 is like your first day of your period, right? So during that early phase of your menstrual cycle, all of your hormones, but both that we're primarily interested in being estrogen and progesterone are low, right? And so it's the lowness of those hormones that actually trigger the bleeding, or the lowness of your progesterone that actually triggers the onset of your period. And so that during that time, some women will feel unwell mood-wise, especially if their estrogen levels dip really low. So that's why I ask women to track those other symptoms like night sweats and hot flashes and insomnia, and their mood, because for some women, they'll say like, I have reverse PMS. Like I feel my worst during my period, right? When PMS truly is like before your period, right? But that low mood during your period sometimes is a reflection of that very low estrogen level, because as it dips down, and I'm gesturing with my hands, which I know for the audio is not super helpful, but as it dips down, into that menstrual phase, if it starts to dip below that menopausal sort of threshold, that's where you're going to see an increase in some of those menopause symptoms, right? Like the vasomotor symptoms or whatnot. So for some women, their mood is garbage during that time because low estrogen will certainly have an impact on depression, or that increase in depression. And as women are become more and more perimenopausal over time, their estrogen spends more time in that low phase. And that's where we're seeing an increase in new onset depression for women, or an exacerbation of depression they already have. Right. And so during that first week of your menstrual cycle, like your hormones are low, and then estrogen starts to like climb back up out of that hole as you get into the next cycle. So the estrogen rises, and then that's, there's lots of other things going on, but that's during like some day 5 to like day 14, that's where we run for prime minister, right? Like estrogen is high-ish. We feel really great, confident. We can run on less sleep, less food, right? Like, so technically like our North American lifestyle impacts us less during that time, right? So our North American lifestyle puts a lot of pressure on our hormones in general, but during like those 5 days, like it doesn't matter as much, right? Because we hormonally are a lot more resilient. So even if you are not like staying up late, overworking, underfueling, it's not as noticeable during that time because you actually are a bit more resilient, and so you feel pretty darn good. And then we transition into that ovulatory phase. So around mid-cycle, assuming that women ovulate, which there's lots of conditions where they don't. And so you can see why mental health becomes such a important piece, like say with polycystic ovarian syndrome, right? Where women don't ovulate. And so they end up with these low hormone levels all the time. And so their mood is really greatly impacted by that. But there's that ovulatory phase where we actually make both hormones, estrogen and progesterone, in huge amounts, right? And so they're very high during that luteal phase. So for some women, that's problematic, right? For some women, that big change in hormones is triggering for them to experience premenstrual or PMDD based mood symptoms. And that it's the change, right? I know I keep saying it, but really it's in the research, what we're calling that is the differential sensitivity theory, meaning that for some women, for their progesterone to go from 0 to 50 is not consequential. They don't notice, right? They don't care. I would say the younger we are, we generally our bodies don't care, right? We don't find that very stressful to have a big ovulation surge like that. But for some women, that change in hormones is debilitating, right? For some, that's triggering really severe depression, really significant mood changes. It definitely causes physical changes like bloating, water retention, breast tenderness and fullness and whatnot. But for mood specifically, for some women, that dramatic shift in progesterone levels is causing or triggering really significant mood symptoms as well. And that persists. And it's, if we don't fall pregnant in that month, about 14 days later, those hormone levels really plummet, right? Which for women who have PMS or PMDD, it's like relief, right? Like those high hormone levels drop back down and they're like, well, thank God, right? And then they feel more like themselves. But for women who are perimenopausal, right, that big drop in hormones actually can be triggering for their mood. And so they don't feel as well. So that's why tracking is so important, because we need to know like which days are the good days, right? Which days are the not so good days. Because the other thing that helps us do is differentiate that whether or not what you are experiencing is hormonal, or if your hormones are just gasoline on the depression you already have.
Right.
And that's really super important.
Yeah. Right. Because you're like, if you're feeling terrible just 1 week out of the cycle, that's more indicative of PMS, PMDD, versus if you're feeling pretty crappy all month long, but then it gets really bad a few days before you menstruate, then,
that's right.
it's yeah.
And the treatment should be different, right? So even though, and we call that a premenstrual exacerbation, right? So it's not premenstrual disorder or premenstrual syndrome. That's premenstrual exacerbation of your underlying mental health issues. And so it's important for us to differentiate those, because the treatment has to be different. And it's, yes, your hormones are having an impact, but we shouldn't be laser focused on your hormones actually, right? We should be treating your mental health from a much broader context if that's the case.
Mm-hmm. Yeah. Yeah. And it's very helpful too to track. I mean, it's validating too, because if you suffer a few days before your period, I mean, a big part of mental health, right, especially when you feel anxiety or depression, is I'm going to feel this forever, or I'm at the mercy of these symptoms and I don't really know, I have no sense of control, or I don't know when it's going to happen to me, or maybe I'm going to feel this way for the next 6 months. But when you get some context around it, it's like, oh, okay, my period's coming in 3 days. And it can take the heaviness off of it a little bit too. Doesn't mean that we don't, we can't work to help and change it and sort of smooth that transition, but it's just helpful to know, okay, oh, I gained 10 pounds. Oh, okay, but my period's coming. It's all good, so.
Yes. Yeah. I was encouraged. I'm testing out a new, like nutrition app. And at the end of the week, it actually checks in to see where you are in your menstrual cycle, which is so cool, right? I'm like, okay, we're finally starting to acknowledge how impactful this is on how women feel. But you're right. Like that, I would say like we don't track so that we're becoming a slave to the situation. But if going to bed a little earlier during those couple of days, right, is going to help us out, wouldn't it be nice to know which nights those were, right? And so like I said, our North American lifestyle puts a lot of pressure on our hormones. We only feel well during that follicular phase because we can tolerate the nonsense that we do all month long, right? Whereas if we were better slept, better fueled, less alcohol, less caffeine, less work, more nature, like these are research proven ways of treating PMS, right? And it's because the stressor of ovulation is only a stress in the context of our overworked urban lifestyle.
Right. Yeah. It's like we should maybe be doing those PMS related foundational pieces all month long, but we can just deal with the 4-hour workouts, 2-hour sleep periods, when when our hormones are kind of on point, like giving us that extra fuel essentially.
Yeah. And we like hang our hat on like being like wanting to feel like that all the time. And it's just that we're more resilient to obviously like the nonsense that we put ourselves through. We're just more resilient to it during those 10 days or so. It's not that we should be able to function on less sleep and less fuel, right? That's like the wrong way to look at it. That PMS is really just a signal that your hormones doing what they're supposed to be doing is too stressful for your body. Because when we contextualize it in the rest of your life, right, there's a lot going on and there's a lot of stressors. And so then the PMS becomes more hardwired as a stressful, uncomfortable situation. Which I find so fascinating, right? Because the other things that predict PMS and PMDD, if we go down like a whole other realm of looking at like, well, why for some women is that problematic, right? Like the amount of trauma and stress and early childhood events and whatnot, like those are predictors for PMS, PMDD, and then depression through transitioning through menopause. So we can't separate those two things, right? We're becoming wired to experience our PMS as a catastrophic event every 4 weeks. And part of that is like because of the other stressors, PTSD and whatnot that women are experiencing in their lifetime, it's wiring them to experience their ovulation as a stressor, which is so fascinating.
Yeah. It's so fascinating because it's almost making me think like the follicular phase is a treatment for early childhood trauma and depression. And then when you go through your luteal phase, that's almost just revealing the baseline of what is, right? Like you said, like you can kind of deal with modern lifestyle when you're in follicular phase because the hormonal state is protective, but when you're sort of in the luteal phase in the last half of your cycle after ovulation, it's like, oh, this is actually just the reality of the situation. You don't really do well with 6 hours of sleep. Maybe you think you can the first part of your cycle, or maybe there is this underlying anxiety because of some early childhood trauma that occurred. And, in the follicular phase, you're just better able to manage that, or it's treated hormonally.
You're just more resilient hormonally. Right. So yeah, it's so fascinating. Yeah. And then that ovulation, like, and then as we transition into sort of that perimenopause, right? Like anytime we don't ovulate, that production of hormones is haphazard. And so we don't get the good estrogen surges, or we have pockets of time where estrogen is low. And even for your listeners, they might recall periods of time where they were fine, and then 6-month windows of time where they were not fine, right? And their period was all over the place, and maybe they had hot flashes, and then maybe things kick back into gear and they're okay again. It's a wild card during that time in a woman's life. And so unfortunately, we start to call all of it normal, right? Like, oh, your period came twice in a month. Yeah, that's okay. That's normal. That happens. You're 46. Versus, right, like a maybe more appropriate approach would be to acknowledge those changes and then how impactful they are being on that woman so that we can provide her appropriate support, right? Because your mental health transitioning through perimenopause has a remarkable impact on the rest of your health, right? Even women's weight management, their ability to, navigate stressors and all of that shifts incredibly if we don't address her mental health during that time. And so it's important. It's not something that we should sort of like shrug off as being like, that is part of the normal human experience.
Like, I know, yeah, I remember, I think you wrote something about how women in perimenopause and menopause will walk 3,000 less steps in the course of their normal day. So they're still doing their workouts and their regular exercise, but just their natural activity levels apart from their structured exercise goes down just because they feel crappy. And so this will create this pretty significant shift in your overall health if you're walking less and you naturally have this like less of an impulse to move because you feel like crap. Like these things, which can be super subtle.
Yeah. And it has a big impact because the way that starts to show up, like you said, it's like, and it shows up in their movement and their exercise. It's funny, like the things that drive women into the office to talk to me about their hormones are not the same things that I'm interested in necessarily when it comes to their hormones, right? For me, I'm thinking about their actual biggest health risks, which still remain for women as, cardiovascular disease, metabolic syndrome, osteoporosis, right? And dementia. So when I think big picture, all of those things are remarkably impacted by hormonal health from a physiological perspective, but also those are things that are remarkably impacted by her behavioral health, right? And so her ability to exercise and move, her ability to maintain healthy lifestyle and diet, her ability to have appropriate sleep, maintain her muscle mass, like all of those things actually are predicted by her mood, right? And those are the things that then become predictive of her top health concerns, actually. So if we shrug off the perimenopausal depression, what we're actually doing is signing a woman up for greater health risk as she ages, because her movement and her nutrition and her ability to manage her health in her 40s is absolutely predictive of her ability to maintain independence in her 70s. And if we don't address it, then we are asking for greater health risk later, which that's what's important to me, right? And so absolutely we can help with your symptoms and your day-to-day functioning and all of that. But the reality is that by shifting those small things, we're having such a big impact on preventative medicine for her as she ages that she's not aware of, right? So when we band-aid the situation with, and I don't want to say that antidepressants are a band-aid. I don't mean that because, again, like I said, they can be life-saving. But if we only do that, right, and we don't address like that wider net that her mood and mental health is impacting, like her movement, we're failing to prevent bigger issues down the road as she ages.
Right. Like if we're just focusing on, because, I imagine that people are coming in with maybe weight loss as a goal or like these, certain things like that can be indicative of these hormonal issues, but you're like, well, I'm actually concerned about your bone density, and weight loss or weight gain is a symptom, and perhaps it could be caused by this reduction in activity that you're engaging in. But how is this all fitting into the bigger picture of your health longevity, Yeah. Yeah. And then, and that's actually an interesting piece too, because I know one of the big topics in this podcast, and then something that you'll talk about a lot, is this idea of restrictive diets, how that can impact hormones, how actually eating certain things, because, diet culture tells us to respond by restriction, and that, and many of us, when we think about nutrition, we think about food, it's usually defined by what you're not consuming. So there's a lot in diet culture. If you think even just like dietary names like vegan diet, it's like, what do I not eat? And now it's called plant-based, but it used to be just about not eating animal products, which I just thought plant-based meant that you ate mostly plants.
Lots of plants.
Yeah,
that's how I interpreted it first too. I'm like, oh, I'm plant-based.
Yeah, me too. I'm like, I'm plant-based plus chicken and eggs. And fish oil. Yeah. Maybe you can speak a little bit to that, because I know you definitely write about carbs and PMS, which would be interesting maybe to jump into.
Mm-hmm. Yeah. So, I mean, it's interesting because there's massive differences between dieting and just good nutrition, right? Which I think they tend to get positioned as being similar to each other, right? That, dieting behavior must mean that you're on a healthier path, right? If you're losing weight, or if the people are losing weight, they're on a healthier path. And that's not necessarily true, especially when we start to talk about hormonal health. And you're right that concept of diet culture is always talking about exclusion versus inclusion, where the research on dietary exclusion is pretty sparse, right? It's very rare that we find a food that if we take it out of a person's life, their health improves. It's very rare that there is a specific food. So when we talk about things like gluten-free and dairy-free and fun-free, right? It's pretty rare that the research actually supports that. There's a few sort of specific case examples, but the idea that women need to be something free is really not well-founded in research at all, actually. And interestingly, so dieting behavior in the research usually is talking about unhealthy patterns of food restriction. So things like skipping breakfast, things like, very low fat dieting. And I would say like taking out all fats in the diet, including non-nutritive foods like Diet Coke and whatnot. Like those are kind of the dieting behaviors that we talk about in the research as maybe having a negative impact on PMS or on hormones. And so we know that women who in adolescence, when they don't eat breakfast, when they are on a diet, that they actually experience their PMS symptoms and their menstrual cramps, and like their entire sort of hormonal health is generally worse when they're engaging in those behaviors. But that's because they're not doing it healthily, right? Like there's a difference there. And that's why this I think is such a difficult topic to talk about, because for some women, their metabolic health would benefit from having shifts in their nutrition that included weight loss, right? But for many women, they have a perception that they're overweight and they maybe aren't, or they're metabolically healthy at the weight that they're at. But the perception of being overweight triggers dieting behavior.
Yes.
So there's some really interesting research on that, and like how women behave if they think they're overweight, whether or not they are. And so we've got that whole side of like diet culture. So there's appropriate positive nutrition and women who do need to help with weight management to have better hormonal health. And then there's diet culture, right? And it's hard to separate those two out. And even I always find this a challenging topic to talk about, because it's hard to know who's listening and how triggering the conversation can be from a disordered eating perspective. When we're talking about healthy nutrition and healthy weight management for women who are on that spectrum of disordered eating, which many are, they take those words and apply it in the context of their disordered eating, and it still becomes unhealthy dieting behavior. Does that make sense?
Yeah, definitely. Yeah. And it's difficult because, even the topic around shame, because even if you're working with a patient who maybe could benefit from some weight loss, even that conversation can be really tricky, because it's very possible that person's been told many times in a very unhelpful way that they need to lose weight, and it's often used as a way to dismiss their concerns, right? So it's like, oh, weight loss. Like many of my patients have had this experience, like, oh, you have knee pain, you need to lose weight. Oh, you have PMS, you need to lose weight. Whereas maybe I'm not correct in thinking this, but I usually consider it as one of the side benefits of generally moving towards a healthier lifestyle. And even with inclusive nutrition, you can create weight loss often because you're maybe by eating more of good things, there's less room to consume the other things. Maybe because there's just a better metabolic state that the patient's in, less stress, even adding carbs, perhaps if it's affecting the stress system, might result in less binge eating, less an overall reduction in calories. Like these gentle kind of gradual shifts can maybe result in weight loss. Whereas I find that maybe focusing as a primary goal of weight loss can sometimes backfire because of the things that people will engage in that they've been taught to engage in, like, oh, just change over to Diet Coke, or don't eat breakfast, or and then the effects on the hormonal systems, like the female hormone systems like estrogen, progesterone, but also our other hormones like cortisol and insulin and those kind of things can be affected in a negative way. So yeah.
Mm-hmm. Yeah, I would say, I mean, there's many pockets or populations of women that need some kind of diet support as it pertains to their hormones, right? Like there's women who, underfueling is going to influence your likelihood of ovulating. And underfueling might look like intermittent fasting or significant fasting for women. Our brain checks in with our hormonal systems every 2 hours, right? We are not the same as men.
Mm-hmm.
And so for women who are underfueling or who are fasting for 16, 18 hours, I think of like that OMAD, right? Which I didn't even know what that meant when a patient told me. I was like, what does that mean? 1 meal a day, right? OMAD is a thing. So women who engage in that, right? And again, most of the research on fasting and, time restricted feeding is on men, but for women who are ovulatory, sometimes restrictive dieting or restrictive patterns of eating are going to influence their likelihood of ovulation. So they skip an ovulation, which may be done once, doesn't have a profound impact on her mental health. Or she doesn't have PMS. And so she's like, oh, this month was better.
Right.
But because she doesn't have PMS, right? Because PMS needs you to ovulate. But the long haul of doing that and not ovulating brings in the other side of mental health when it comes to hormones, meaning like the low hormones. So women with, anorexia or amenorrhea, because of their disordered eating, suffer greatly with their mental health in terms of depression and anxiety. And part of that is driven by their low hormones because they're not ovulating.
Mm-hmm. Like cycle.
And so, so that's like the other side of it. So certainly women benefit from appropriate fueling, meaning that being in that window and range of calorie needs to make sure that her body has enough. And funnily, women, again, I'm gesturing with my hands, so it's not helpful. We do have a range of maintenance calories that women don't realize because they're always shooting for this bottom number, right? Like women spend their whole life trying to figure out how little they can eat to lose weight without realizing that they can comfortably live in a big window of 300 to 400 calories without having any impact on their weight. The problem is we swing from being over here to being over here with those sort of more binge pattern of behavior, and that women never learn how to comfortably live in the middle, right? That they're either doing things totally perfectly or they feel like they're totally effing it up, when really it's because that restrictive pattern of behavior is a predictor for binge eating behavior. That nutrition knowledge is probably the difference, right? And we do know that if women feel confident about their nutrition, if they feel like they have locus of control over their health, they live over here in the middle where they can actually manage their weight and manage their caloric intake in the long haul and not just do a 2-week diet followed by a 3-month binge. Which is what we typically will see in the research. So the restrictive pattern of behavior definitely has an impact on mood. I always joke and I tell patients, like the only studies that have been shown to cure PMS with nutrition actually intentionally fed the women bread.
Amazing.
Which then the ongoing joke is, well, they could have just asked me, right? Like they didn't need to run a study. They'd say, Jordan, how do you cure your PMS? I'm like, I eat bread.
Yeah, you're like, do you eat chocolate or chocolate?
Yeah, that's right. This is how you solve it.
Yeah.
But it's because that increasing carbohydrate during that time, it liberates, or what we think is happening, we think it liberates amino acids into the brain more readily during that period of time, which improves our mood. So it increases serotonin levels to eat carbs. So you can imagine if women are eating keto, or very low carbohydrate diets, that their PMS cravings, A, are going to be atrocious, but B, they're actually not honoring what we think needs to happen physiologically during that time to actually improve her mood. And so feeding her carbs intentionally improves it. Now, habitually in North America, we blow that out of the water, right? So where one piece of bread probably solves our PMS, we eat an extra large pizza because the impact that culture has on cravings in North America is really significant. So when women identify as having PMS cravings, they don't think, oh, I'm going to make a half a piece of toast, right? Because of their restrictive dieting, they order an extra large pizza instead. And so when I tell women that carbs treat their PMS, they're like, oh no, it doesn't work, right? I've tried that and I gain weight. And it's because we're living in this like such extremes of nutrition all the time that women, again, don't know how to comfortably live in this gray zone in the middle. But technically carbs are the only dietary treatment for PMS that we know so far.
That's pretty good.
The other study gave them a carb drink, which I think is way less fun than just getting the bread.
Yeah, it's like, what would you rather have? Some gross like Ensure or whatever.
Yeah, that's what it was, like a carbohydrate powder that they had to put in their water. I'm like, I would have just, I wanted to be in the bread study.
Yeah, I wanted give me a muffin. Yeah.
Yeah. And then, I mean, the other side of nutrition and hormones and, you know, those patterns of eating and behavior is that like how substantially mood impacts appetite and our ability to emotionally regulate our eating behaviors. And so, yes, like hormones have a big impact on weight management, but a lot of it has to do with just how they make us feel. So when women don't feel well or they haven't slept, they binge eat the following day, or the foods they are attracted to the following day are not healthy for them. Or they're very calorically dense, right? Or they're what we call in the research hyperpalatable foods, which, you know, they've done studies that we eat chips out of like more calories per minute when we're eating chips versus if we're eating blueberries. And so that when we don't feel well, right, we're also being set up to struggle with our nutrition. And so like you said, if we actually address the bigger challenges in health, the consequence is improved weight maintenance and management because we're helping that woman not feel so crappy. She eats the blueberries, right? Because if she eats the chips, we can't, like, we're in a spiral.
Yeah.
Does that make sense?
Yeah, it's like if you have the good, and this, I'm working on a foundational program, so I'm thinking about this a lot in the terms of the nutrition lesson, but it's like if you have these good foundations where you have, you know, an appropriate amount of carbohydrates generally every day or every meal, then when you get into your luteal phase and you require maybe more carbohydrates, it's just a shift from 1 cup of brown rice to 1.5 cups or 2 cups, you know, as opposed to no carbs, fasting, and then the extra large pizza, which is creating more of that roller coaster that you're already on. And
it's not that the extra large pizza is wrong,
right?
Right? Because again, there's no shame in the diet choice, right? But it's that pattern of behavior that's predictive of long-term health. And so the 1 extra large pizza in 6 months because you have a massive PMS craving is not the problem. But if every 2 weeks we're in an unmanageable state, right, as far as nutrition goes, that's 50% of your time, right? That pattern is not going to work for women in the long haul. And that's where we want to have those impacts so that the pizza is a 1 in a million and not one every, 12 days.
Yeah. And it's an intentional experience. Maybe you're actually enjoying your pizza, not feeling guilt, shame, and then responding by restricting the next day because you feel bad about it and not sure why it happened. And there's a lot around food. Like it's not, I mean, sadly, we just don't consider food as like your car doesn't get upset by the gasoline it's given. It's not like, there's a lot around food. Yeah.
And the deeper that I get into my work with women, the more like process oriented I've become as far as educating around nutrition, because I've, and really the research reflects this, is that women can lose weight if they're in a program. And then the day it's over, she starts to regain it. And that is how women experience their nutrition life outside of my office too, right there. And if you ask them about their weight management and whatnot, and I know we're shifting to a slightly different topic here, but that's what she reports, right? It's been a lifelong battle. It's been a lifelong struggle. I've had to deal with this my whole life. And when we look at it, like at its very root, her nutrition knowledge has never shifted in any of those times, right? She's applied one particular concept that then was helpful or successful for her for 3 weeks. And she had zero confidence when it was over, how to maintain it. Or she had zero understanding of why it worked in the first place, right? Like, I don't know why Weight Watchers worked. It just worked, right? And so then when she's not doing that thing, then she has zero capacity for being able to self-regulate when she leaves. And so my work with women has shifted to be much more process oriented. It's like, I need you to understand this, right? I need you to be able to point to the protein on your plate and not just eat 3 ounces of chicken because that's what I said. Because then her confidence grows that she can go on a trip for a week and come home and know she's okay, right? Or she can have a busy season at work and know where she's making nutrition choices that are maybe, a little over, maybe not perfect. But then when that busy season is over, she knows how to pull herself back in, versus this feeling like a loss of control over her diet, or that the control is in someone else's hands, right? Which we call like an external locus of control, meaning that like my nutritionist or my hormones or my age are influencing my nutrition. We want that woman to feel this internal locus of control over her nutrition so that she feels super confident moving forward with it. And then she can navigate like, crappy periods in her life and not feel like she's starting from scratch, because she has skills, right, to like move through it. So that's where I see the sort of future of nutrition going, is that we need women to just feel confident in their knowledge about nutrition so that they can navigate the like ups and downs. I almost said waves, which is like totally in your surfer.
Yeah, exactly. That's why I like just hormonal.
That's how I feel about it. That's my like big picture message around nutrition, right? It's like, it has to be a process, like a learning process, because otherwise I think we're totally missing the boat.
Actually, I love that. And it's very validating for my program development, but also you put it in a really good way that you've articulated in a really amazing way. Because it's like, that's what I want from patients, is for them to understand like, where's the protein on my plate? How do I feel when I have X amount of protein versus Y amount of protein? Understanding those like after dinner food cravings that are really common, and figuring out like, it's not just about that moment or willpower, but I think, and you've written about this, like what happened the 9 hours before you ate the bag of chips. And again, not that the bag of chips is wrong, but understanding how, our nutritional choices and our nutritional foundations play into our cravings, what we end up eating, our overall health, and being able to, like, I talk about meal templates, because some people are like, oh, I don't have much time, so I throw pizza in the oven. And so like breaking down, okay, well, how do we kind of get the protein, the produce, the fats, the carbs on your plate in a balanced way, and how can we understand sort of these components of what you're eating, and then the more important thing is, how does that affect how you feel? And and being able to kind of use yourself as an experiment to figure that out, and to be connected to your nutrition, versus, like you said, having just kind of the nutritionist tell you to put 3 ounces of chicken on your plate.
Yeah, I think that translates into better long-term, right? Because and I always tell my patients, I'm like, I don't want to be in your life for 21 days, right? Like that's not my role at all. And if that's what you want, right, this is not the right place. This is not the good spot or right place for you to be. I want to be in a patient's life for 10 years, right? I am talking about her metabolic health and her osteoporosis and her dementia risk. Like, I'm talking about those things. And so what I need her to do is be on this, more of a journey when it comes to nutrition, again, so that she can navigate those ups and downs. Because what that 21-day plan doesn't accommodate for is that you don't have time or the desire for your nutrition to be 85% of your mental and emotional capacity at any given time.
Yeah.
Right. But when we do a plan like that, that is what that is, right? If you're doing a 21-day, say juice cleanse or whatever, right? You can fill in any unhealthy dieting behavior in there. It occupies 100% of that patient's mental space during that time.
Yeah.
And so then when she has a deadline that she needs to meet, or her kid has a hockey tournament that they need to go away for the week, she has no idea what to do, right? She can't navigate it because it's like, well, I might as well go back to eating. I always use grilled cheese as an example because that's one of my comfort foods. But when shit hits the fan, we just eat grilled cheese, right? And we don't actually pull forward the skills that we learned during the plan because that's not what that plan was about, right? That plan was so extreme that it took up so much of our mental capacity that if we need to put that down for a little bit, we just go back to the way things were, right? We don't do the walk. We don't do the supervised exercise. We don't do the nutrition. But what we need to do is figure out, how do we pull some of those behaviors forward, or how do we help women understand what those behaviors are doing to how she feels and her health so that she feels more empowered to do them, right? If she doesn't, like you said, if you don't understand how you feel with respect to your hormones, your nutrition or whatnot, it makes you feel completely out of control. And like we can't do anything about it. And that hopelessness is highly predictive of poor mental health, which I know you know. But it also means that we don't pull forward any of those healthy habits and behaviors in tough times. And that's when we actually need women to be able to do those things, because we've got lots of tough times, right? Our life isn't these like 3-week pockets of, time where we can devote 100% of our time to nutrition.
Right. And
there's real life, right? Like there's all this real life. And so how do we help women be able to take care of themselves during those times? That's what I'm interested in.
Right. Yeah. Because I think a key indicator of maybe this isn't a good lifelong plan to be on is like, oh, I can't start this because my brother's wedding's next week. And it's like, but you should be able to stay on or feel like you're, fueling yourself or nourishing yourself. And then your brother's wedding shows up and you go on vacation and you're just kind of like riding these gradual waves rather than 21-day juice cleanse and then all out, just forget it all, And I also tell my patients, I'm like, like the goal is for you to not need to think about this all the time. Like my job is to pay attention to food because I get paid for it to know about nutrition and think about it. But like, ideally you're just eating, and it just kind of feels right when you look at your plate and think like, or like your mother-in-law serves you a plate of food and you're like, oh, where's like the protein? Where's the fiber? And like, you're just kind of, it feels kind of off.
Where are the vegetables?
Where are the vegetables? It feels like a lot of just like starches.
Lasagna.
Yeah, exactly. It's just lasagna. Yeah. And so just kind of having this intuition around it, and it just becomes part of behavior, general behaviors versus like, I don't know what to eat now because I'm at a roadside Tim Hortons and I'm starving, and none of these things that Tim Hortons sells are part of this juice cleanse I'm on. And you're like, so what do I do? Yeah. And actually, so this is a big segue, but to bioidentical hormone replacement therapy, because as we're talking about these hormonal transitions and the effects of estrogen, particularly one of the hormones, like let's talk about BHRT, because I mean, definitely there's a growing interest. You referred to the 90s, and so maybe actually let's go through the journey of BHRT, if that's not too long of a conversation. And
yeah, sure. Yeah, the short answer is we were wrong about a few things, right? Like so I would say, if as a listener, if you hear hormone replacement therapy and your skin crawls and you get goosebumps and you think, oh my God, this is dangerous and scary, you're missing some information there about it. So the big sort of, there was a massive study that was stopped prematurely, meaning that they stopped it early, called the Women's Health Initiative, where they studied women that are not necessarily like you. So they were studying women, and I don't mean you, Talia, I mean you, like the listener. They studied women who were quite a bit past their menopausal period of time, right? So they were older women. They prescribed them hormones that we no longer use, right? And they watched them and found that they had an increase in some cardiovascular events, meaning that they had higher risk of stroke or clots. They alluded to an increase in breast cancer, although that wasn't true, right? And so they stopped the study prematurely, said hormone replacement therapy is a scary thing, and it dramatically changed prescribing practice in North America and in Canada for, well, I'm going to say indefinitely after that, because I will say I still even come up against practitioners who are using more belief-based decision-making around hormones than science-based. So that study really was a big turning point. And even in Canada, they've published a Canadian study that watched the decline in hormone prescriptions after that time and the increase in SSRIs or antidepressants after that time. So women's needs didn't change. So women still had hot flashes, depression, changes to her body and whatnot after that study was published, right? The health of women was exactly the same, but the prescriptions that we used to manage it shifted really dramatically away from hormone prescribing and towards more mood stabilizing medication in that time period. And that's a Canadian study, right? So we know that's very relevant data. Not every country manages every health condition the same, but that's a Canadian study. So since that day, so when you say it in that way, right, they studied women who aren't you, right? They're quite a bit past menopause, 10 or more years since their last menstrual period, which we do feel like there is a bit of an opportunity in those 10 years after your last menstrual period. And now arguably we're treating women even before that. Remember I said, just because you have your period doesn't mean things are good. So we're actually backing up and treating women in peri-menopause now with hormones for their mood specifically because that low estrogen experience. But we should be treating women in that first 10 years. We use different medications than we did then. And so, if we applied that same sort of concept in other areas of medicine, it would be like saying, chemotherapy that we developed in 1950 was super toxic. And so we probably shouldn't use it now.
Oh, right. Yeah.
Right.
Yeah.
Right. Or, the way that we used to treat patients with cardiovascular disease wasn't super helpful. So let's just can it. Right.
Right.
In every other field of medicine, we've watched an evolution in the medications we prescribe and how precise we can use them. Right. We learn who benefits the most, under what circumstances, what are the true risks in the long haul, right? Not just in the 3 months we studied them, but over their lifetime, what are their true risks and benefits? And the medications themselves have actually evolved in every other field of medicine. But for some reason in women's health, that one study became this turning point where we said, we don't care if the medicine gets better, and we don't care if we studied the wrong population or if we're learning that these women benefit immensely and these women don't. Nobody gets hormones, right? Which is really not an appropriate way to treat it. And I can certainly turn the argument into a feminist one if I wanted to. But to keep it super medical, things have shifted quite a bit. And so we now use transdermal estrogen, which means it goes through the skin because oral estrogen was what was the problem. We use different progestins, meaning the synthetic progesterone, or we use just straight up progesterone, because what we learned from that Women's Health Initiative is that the progesterone arm or the synthetic progesterone was maybe what was contributing all the risk in the first place, not the estrogen. So it's shifted quite a bit. But what we know is that, giving women hormone replacement therapy during that perimenopausal window of time benefits her health immensely, in all areas, whether we're talking about where she carries body weight, whether we're talking about her quality of life symptoms like hot flashes and insomnia, or whether we're talking about her mood. We can treat perimenopausal and menopausal depression by giving women estrogen. And so we do need to expand that conversation, because maybe Prozac is the right choice from a mood perspective, but it doesn't do any of the other things. Right? It doesn't change her body composition. It has a negative impact on her sexual function. It doesn't treat her vaginal dryness.
Bone density,
her bone density.
Yeah.
Exactly. Right? It's a very narrow approach. And certainly for some women, especially if they have an absolute contraindication for hormone replacement therapy, then sure. Right? That is a great option. And again, life-saving for lots of women. But if the root cause is hormonal, and we know that we have improvement with it, and the improvement actually is more broad scale as far as her whole health, then we really should be looking at that option first, right? And maybe in those women who are treatment resistant, we talk about, using an antidepressant or some other option for her depressive symptoms. But if we give women estrogen during that time, with or without progesterone, we do see improvements in her mood and all those other areas of her health. And so that really needs to be considered like frontline therapy. Yeah. And I'll say in my experience, like, my clinical experience, I do still find that many physicians are hesitant to offer hormone replacement therapy. And we've put sort of, because we have so many subspecialties in medicine in Canada, especially, and it's hard to access all of those subspecialties, right? Like, does your gynecologist prescribe estrogen for your mental health, or does your psychiatrist?
Right. Or your endocrinologist, or your
endocrinologist or your family doc, right? Who unfortunately is just kind of like stuck in the middle. So we've got this issue with, it's almost nobody's problem, right? So your gynecologist is probably not screening for your depression in the first place, and is probably uncomfortable giving you medication for your depression. It's just not her game, right? Your psychiatrist, by the time you get theirs, toolkit looks like antipsychotics, second generation mood stabilizing medication, and hopefully some CBT thrown in there. Although again, right? But their domain expertise is in that realm of pharmaceuticals, not in the realm of hormone prescribing. And then we're asking your family doctor to prescribe hormones for your mood. Right? Which is putting them in a really uncomfortable, awkward position. And so this is why I think we have such an issue accessing hormone replacement therapy for mood-based symptoms, because it's almost nobody's problem, right? Except for the woman's.
It's like no one's sort of putting it all together and saying, oh, you know what? I think that, natural estrogen replacement therapy could just kind of solve all of these things that you're experiencing. It will help your bone health. It'll help your libido, the vaginal dryness, the mood, the hair loss that you're upset about, like all these things.
All the things. Yeah. Your joint pain, right? Like all of those things. So it really puts the onus on the woman, right? Or if she's so lucky to have horrific hot flashes and low mood, someone might treat her, right? Rather than if mood is your primary symptom, or if that's a symptom that's creeping in at 47, 48, even though you're menstruating, right? It still is hormonal, right? The origin of it is still hormonal, but nobody's going to treat you.
Right. Yeah. And then I think, another thing, it's interesting though, because essentially oral contraceptives are hormonal replacement therapy. Extremely common, and they're used to treat anovulation, like in polycystic ovarian syndrome, although they're not treating that, they're just creating bleeds and quote unquote regulating the cycle. But it's interesting that could be a first line for hormonal imbalances, although it's not necessarily treating the hormonal imbalance. But then with estrogen replacement therapy, where you're going through peri-menopause, and that is actually the cause of what's going on in the symptoms that someone's experiencing, it's often, and I think, even as a clinician, like the hesitation around it, because you feel uncomfortable if patients feel uncomfortable too. So they've read about certain things, and maybe their healthcare team is also cautioning them against hormone replacement therapy. And so, I always feel uncomfortable, like recommending something that my patients are nervous about, and especially
and I'll say that to women too, like they have to be quite confident in what we're doing or what they're doing in order for them to have success, right? Because it's not an overnight sensation. So we do expect that the majority of symptoms have improved, whether we're talking about vasomotor symptoms like hot flashes or mood at that sort of like 12, 16 week mark, right? Like it's a slower build than other treatment options. Again, more significant impact as far as overall health, but it takes longer to see the benefit. Oh shoot, I just lost my train of thought. But they have to be pretty confident. Because they can't just like take it for a week and be like, oh, I feel better, right? Like that's not, there's a buy-in there that has to happen for sure. And I'll say the women that are transitioning through menopause right now are really in a kind of a, crappy generation, because their mothers were told that they were going to be killed by HRT, right? So the women who are in their like 70s and 80s are the ones who were at the peak of the misinformation. And so if they ask their mothers are like, oh my God, don't touch that with a 10-foot pole, you're going to die of breast cancer. Whereas my generation, right, I'm 38, by the time I become, and I actually use HRT for my migraines, right? So I take estrogen for my menstrual migraines myself. By the time I get there, it's going to be a no-brainer, right? The research will have been, like we said at the very beginning, right? It takes 10 years for something to become public health policy. By the time I get to menopause, the answer will be different because finally we will have accepted, right? The Women's Health Initiative will be 30 years old and we'll say, oh, that was old news. Now we treat women. It's the women who are 50 today that are struggling and that maybe are not getting offered the treatment solutions that make the most sense. And if she looks ahead at what her mother experienced, right, she is worried. And even if she talks with her friends, like they're worried, right? I would say like pointing to good resources can be helpful. I often recommend, some reading or particular podcasts about HRT, which can be quite helpful to help them understand the risks and benefits. And what's come out of all of that research in a nice sort of summarized way. But also know that it's not an emergency, right? Like you don't need to be prescribed it right away. It's something that you should take some time to understand and be super confident in before you start. And you can also stop, right?
Yeah.
That's the other piece. Like you can stop.
Right.
There's a few MDs that talk about hormone replacement therapy, and they're like, well, you can stop as soon as you want to stop having the benefit, right?
Right, exactly. Yeah, because people are like, how long do I take this for? Like, when do I stop?
Well, when do you want to start feeling shitty again?
Yeah, exactly. Yeah, and so I'll talk about that with patients. Like, okay, we can start with, phytoestrogens and plant medicine and see how far that gets us. And then if we're not getting the results, sometimes, it can have an effect and just help kind of smooth that transition, but often it's not enough. And so then we have this other option that we can pull out and see, but there's
I feel like if we had some other medication that prevented osteoporosis, prevented dementia, prevented depression, improved body composition, improved sleep, decreased hot flashes, improved sexual function, that wasn't estrogen, right? They'd be trillionaires.
Right.
But for some reason, because the answer is estrogen, right, it's made everybody a little uncomfortable. And women will often say, well, it's natural to go through menopause. I'm like, no, it's not natural that we live this long, right? Like we're the only species on Earth that lives beyond reproductive years. Every other animal, the moment they stop having kids, they start dying. Right? And so what's unnatural is that women are living 50% of their life without any hormones. And so I always find it so interesting that we want to use modern medicine like to a point, right? Like we want to use modern medicine and protein powder and all the like beautiful evolution of science to help hack our life. But we're unwilling to have a conversation about HRT. And that's like the ultimate health hack, right? It's like, if we've learned to live till we're 70, like, are we asking women how good those years are?
Right.
Right.
And that's probably when you're running for prime minister, like you're probably
that's right.
Running
We need to feel really good into our 60s so that we can run for prime minister. And we're probably on HRT, right? Like while we're doing it. So it's interesting because when we reframe that conversation and think about it in those different ways, right, it can really help contextualize it for women. Like, why am I so concerned about it? Why did I think it was natural for me to, have my ovaries wither away and then try and live another 30 years after that? Because I think, and again, not to make it a feminist issue, but I can on a dime, when this happens to men, we offer testosterone replacement therapy like in an instant.
In a second. Yeah. And it's often, we talk about testosterone a lot. It's like, oh, this is happening. Oh, let's check testosterone. And it's like, maybe it's more about, cholesterol and like, maybe you just need to work out.
That's
like,
right. But really if we said to men, you're going to live 30 years with no testosterone. Right? Like their good fortune is that their decline is slower. I mean, in a way that's harmful for them because sometimes we miss the mark that testosterone is a problem because they have this insidious onset of their depression versus like an overnight sensation that women experience when the hormonal carpet gets pulled out from underneath them.
Right.
But we offer it a lot quicker and more liberally to men when we've pegged their hormones as being part of the problem. Whereas for women, we kind of dance around it, right? We're like, well, you should be fine. It's just quality of life. That's my favorite. I've had that recently from an obstetrician, told my patient, well, you can do it if you want. It's just quality of life.
That's amazing. Oh my gosh. Who cares about that? Yeah. It's just quality of
Right.
life.
Yeah.
You can't measure that.
If you want to, I guess. You selfish woman, wanting a good
quality of life. We just rate it on a scale of 1 to 10. It's a subjective assessment. This is how we began the conversation, right? It's like, we don't like subjective. So it's like,
that's right.
We can increase our subjective quality of life, but that's not useful for a study.
That's right.
So yeah, it's not study success. We can't measure it necessarily. Well, you can, but we like to just measure things.
We like numbers.
What's the connection? So you mentioned in the Women's Health Initiative that it was suggestive of breast cancer risk, and that's often the thing that we'll go to, and that's the thing that creates the most fear, I find, more than the blood clot risk. And what is the actual data like? What's the latest around that?
Yeah, it's super complicated.
Yeah, okay.
So, and probably outside the scope of this particular conversation, I'm going to say that the short answer is that we don't know, edging on the side of we don't think it has a negative impact, right? And so part of the problem with this is that we have lots more discovery of breast cancer, right? Like our detection methods are high. Our survival is super high. Our, like the way that the data has shifted over many years makes it really difficult, and cause and effect in medicine is almost impossible always, right? Like if you think about how long it took us to say that smoking caused cancer, even though that feels like a no-brainer at this point, it took a really long time to make that sort of cause and effect statement really confidently. And we probably will never get there with estrogen, right? Like if we put estrogen in a petri dish with breast cancer, it grows. But does that mean that the woman dies from it? Right? And so that's when we look at like the bigger picture as far as like breast cancer related mortality and and breast cancer incidence, we don't think that there's an increased risk of getting breast cancer if you do hormones or don't, meaning that whether you do it or not, your risk is the same, right? Your breast cancer mortality is probably not predicted by using hormone replacement therapy, right? Meaning that whether you did it or didn't, you don't die from your breast cancer any more often if you've had hormone replacement therapy. Certainly there are populations of women that we think are higher risk, right? Women who carry the BRCA genes. But even that in them, we have some studies that show that HRT can be done safely, sometimes, right? I think, and that's why I say it's a bit outside the scope, because every individual woman needs to have that conversation about risk-benefit ratios with their practitioner so that they can make a really confident, educated decision about it. Because if she only has hot flashes, otherwise okay, lean, has good muscle mass and whatnot, maybe we look at SAGE, right? Like maybe we just treat her hot flashes and call it a day. If has other risk factors that made us maybe feel uncomfortable about giving her HRT. If a woman has zero risk factors, her hormone loss is pervasive through her health, she's high risk of metabolic syndrome or diabetes, which we know estrogen prevents, our risk-benefit ratio there is really good, meaning she's way more likely to die of diabetes and heart disease than she is of breast cancer, so we treat, right? But those big picture conversations, again, those aren't the ones that are being had, right? We distill it down to hot flashes, yes, no, right? Can we accomplish this in a 7-minute conversation at the doctor? Versus like taking a step back and being like, what are your big goals here? What are our big risks? What's standing in our way of you having a functional, happy, healthy, independent life in your 70s? And let's develop a plan on how to get there. And sometimes that includes HRT. And sometimes it doesn't. Right?
Totally. Yeah. And we like certainty, and we don't necessarily have that when we're looking at long-term health, and it is like that nuanced conversation between, okay, risk. I can't guarantee that you'll never get breast cancer, but what the data is suggesting is that it's probably not going to be impacted by whether you take HRT or not,
Right. Yeah. Which is tough because like that's population statistics. Right. But then if that one woman gets breast cancer, how does she feel? right?
Right.
And so as a scientist, I can deeply know if something happens to me that the statistics of it happening were pretty poor, even if it happened, right? Like I can say, well, the odds of that happening to me were so rare that it happened, right? But when it's you, right, when you're and when women don't come from that sort of like science base, it's really tough to separate those things and to say, I know I'm on HRT, but my breast cancer statistically is not being caused by it, right? Like our brain doesn't really work that way. We look for more emotional connection in what's happening to us versus like a statistical connection. But that's why I say women need to be really confident in what they're doing, and they need to like know that the benefits that they're getting from treatment are having a more remarkable positive impact on her health than worrying about the risk of the negatives. Because again, the vast majority of women who are diagnosed with breast cancer also survive. Right. And so even though we don't think your HRT is being a cause for it, if you do get diagnosed, your likelihood of survival is very high. Women who get diagnosed with heart disease, that's almost a shoo-in, right? As far as that being her cause of death.
Yeah, that's so cause of death for women. Yeah.
Right. Like, so if we take a big step back and say, well, maybe we have treatment options that prevent that. Right. It's a cool conversation, right? Because we're often not educated in our health about that, like that way, right? We're not thinking that much big picture about our health.
Yeah, it's kind of like, if you get struck by lightning running through the park and you're like, that's it, I'm swearing off running. You're like,
that's right.
It's very rare to get struck by lightning. It didn't happen because you were running, just wrong place, wrong time. And statistically.
Yes. Yeah.
Yeah. Yeah. But it's really hard. Yeah. Like you said, like we want to know when you're working with an individual person, you want to be helping that person with their specific context and their specific goals. And then also, that person, like all of us just want to know, like, what's going to happen to me in 20 years? And you have all this knowledge. So can you just, tell me whether I'm going to get breast cancer or cardiovascular disease and tell me how not to get it? Yeah, it's tricky. Yeah. Yeah. And so any last thoughts, Jordan? This was great. This is a great conversation. Yeah.
Last thoughts. I mean, I think what I always want women to, sort of feel empowered by is that, their changes to their mood is not all in their head. And I know you've talked about this on your podcast before, right? But like, if you think there's a hormonal connection, there probably is, right? To your mood symptoms specifically. And I would say the most sort of empowered forward thinking you can do is to kind of track it so that you can have a really productive conversation with your practitioner. And I want women to feel like they can be strong advocates for themselves for the kind of care that they need, right? And recognizing the gaps in what's currently offered to them, I think is a good way to think about it. Like that whole conversation, like, is it your gynecologist who treats your mental health, or is it your psychiatrist who treats your hormonal health, right? Is that there is a natural gap in the way that we're approaching women's health right now that is like not to our advantage. And I think when, like, as a woman who's so interested in the science, the reason I'm so attracted to women's health is because the answer is an integrative approach, actually. So when we look at like best case scenario, best evidence, it's actually to treat her more holistically and with an integrative approach, right? Whereas, and I used this example the other day, if someone has appendicitis, that an integrative approach is not appropriate, right? It's like
just take it out.
Just take it out. Just go to the hospital, take it out.
Yeah.
But when we're talking about women's health, the evidence is that we should have an integrative approach. Whether you have PCOS, whether you have amenorrhea, whether you have peri-menopause, the answer is we need to develop a plan for you that is more all-encompassing versus polypill or strategic prescriptions. And so I want women to know that so that they can kind of advocate for the kind of care that they deserve, because what she will naturally be offered is that, one pill, one problem kind of solution. And so that, I want women to feel empowered and like they can advocate for themselves.
This is awesome. Yeah. And I love that idea. Yeah. And that's why I'm drawn to mental health too. It's the same reason. It is an integrative approach, right? We just don't have enough solutions in the pill. And so it is about lifestyle and, using these other things. And then I think hormones are integrative in and of themselves. Like you said, like one hormone has all encompassing effects on the body. You know, estrogen works on virtually every cell in your body. And so it's not just about like, oh, depression, estrogen. That's the one thing it does. You know,
right.
Mm-hmm, mm-hmm. Well, this is awesome. So there's links in the show notes to how people can find you.
Awesome.
And thank you so much for joining me, Jordan. This was awesome.
Yeah, you're welcome, Talia. Yeah, I put lots of information out about this, like mood and hormones and all of that, in, Instagram is probably the best way to connect with me. That's what I love. And all the links to like resources that I have or things that I find helpful for women to learn more about it, they're all there as well, including some like freebie downloads about, changes to your body that happen in perimenopause and menopause. So if any of that's useful for your audience too, they're all there.
Yeah, perfect. Yeah, and your Instagram account is really awesome. So I recommend everyone follow Jordan. It's very good. It's very entertaining.
Awesome.
Very shareable. Yeah.
Thanks so much, Talia. I totally appreciate being able to share with your audience.
Thank you so much.